Welcome to the Health on Track podcast. Let's talk well-being.
Welcome to the Health on Track podcast, offering you a shot of wellness. I'm Yasmin, and I'm the Member Engagements and Communications Manager at GIG Gulf Insurance. We're all familiar with headaches, and maybe you're even familiar with the fact that there are different types of headaches and that their causes differ. In this episode, we'll be talking about the worst one of them, migraines. Joining me today is Dr. John, specialist neurologist and clinical neurophysiologist from King's College Hospital, Dubai, with several years of experience. He pioneered the Clinical Neurophysiology service and works as a full-time clinical neurologist, seeing a broad range of neurological conditions. He has special expertise in headache medicine, epilepsies, and peripheral nerve disorders. He has also a keen interest in dizziness. Thank you so much for taking the time, Dr. John, to be here today.
Thank you for having me.
Okay, so can you briefly tell us about the different types of headaches?
All right. When we talk about the types of headaches, I think a very simple way to look at it is there's what we call primary headaches and there's what we call secondary headaches. So I will start with the secondary headaches. When somebody has a flu, for example, they can get a headache. When they have COVID, they can get headaches. If they have high blood pressure, very, very high blood pressure, occasionally they may get some headaches. Let's say if they have a stroke, they can get headaches, brain tumor. So all of these things in which you can pinpoint something going wrong, causing the headache, is a secondary headache. Now we have another category that we call primary headaches. So these are situations in which the individual actually has nothing wrong with the brain or the body, yet they have headaches. So the headache is existing as a problem on its own without something else causing it. So that's a primary headache. So that's like the simplest umbrella under which we categorize headaches. So if someone walked into my room today complaining of headache, I'll be asking them so many questions within the time frame of the consultation. But the aim of all of the questions is to put them under one of these two umbrellas. Either they are having primary headaches, in which I know that this person, no matter how bad the headaches are, they would never come to any harm in terms of whether it will kill anybody or maim anybody in the future, or I need to worry about anything, nothing else. So I'm more relaxed, and then I can take my time to treat that headache as it is. But when I find features that suggest secondary headache, that's when I worry. So maybe up to 10 to 5% of people who come with headaches would have secondary headaches. Maybe they have some brain tumor or they have something else. That's what worries me, and I have to find what is underlying that headache. So that's like a very simple umbrella under which to pull the different kinds of headaches.
Yeah, that's a good explanation, actually. So what are migraines? Are they primary or secondary headaches?
Yeah, I'm glad you're following it, and I like the way you actually, that's a very, it suggests you understood it. So migraines actually will fall under primary headaches. So it means that there is nothing underlying it. There is no brain tumor, there's nothing else. So the headache is the problem itself. So when people come in and I have gone through all the questions I should ask, at the back of my mind, I have an outline, and I think I haven't found anything sinister, so just the secondary headaches, then I come to primary headaches. Now, primary headaches, again, there are so many types of them. And the treatment people get depends on the type of primary headache we diagnose at the end of the day. So migraine is just one of the primary headaches. Okay. And it's one of the commonest reasons for which people actually come to the neurology clinic. So when somebody comes in my mind, I'm thinking there's a 90% chance that this is a primary headache. There also is a 10% chance that's a secondary headache. So once I've teased those out and I know this is primary, the chances are very, very high that probably 4 out of 5 that this is a migraine. So it's the commonest primary headache.
Okay, so what is a migraine? Like, how do we say I have a migraine or I have a headache?
Okay, so let me start this way because I've talked about this subject a lot of times, and something I often forget to say is what I would say that first, so I don't leave here regretting slightly that I didn't make that clarification. And that is the fact that somebody that has migraine will have headaches
Okay.
by
They're not the same
definition.
thing.
They are not exactly the same. At the end of this podcast, you will understand it.
Oh.
So, migraine, people use the word migraine into kind of contexts. Both contexts are kind of correct, but to me as a neurologist, the second context is more important. The first context when people use the word migraine is people already have something at the back of their minds. Perhaps that's what you have at the back of your mind, that certain types of headache maybe on one side of the head,
Yes.
and you cannot bear
The light
light.
sensitivity.
Exactly.
Yeah.
You're feeling nauseous, you want to vomit and stuff. So that's correct. So that's the way to kind of profile. That's like profiling what migraine looks like. But migraine also can be heterogeneous, can manifest in a different way. So now that brings us to the second context, which is the most important context that I tell patients in the clinic. It's interesting that I see patients who have had migraines for over a decade, and they never really understood what exactly is migraine. So they only go around with that first contextual definition of a type of headache, wherever. And then when I ask them, okay, now you got a migraine headache, so what's causing your migraine? I say, I don't know. So that brings us to that second context that I like you to understand and all the viewers to understand. And that is that migraine is actually the reason for which they have those headaches. So migraine is a disorder.
Okay.
It is a genetic disorder where people are genetically programmed to get headaches.
migraines.
To get, yes.
To get headaches.
So their brains are fine structurally. If you could open the brain and examine it, it would look exactly like mine or like the brains of other people without migraine. But the way it functions, the way the chemicals behave inside the brain, the way the systems in the brain behave is in such a way that they are very, very sensitive to pain. So this brain is just programmed to cause pain. That's what migraine is.
To cause pain.
Yes. So
That's unlucky.
yeah, so you can think you can say, but a lot of migraine patients are quite very bright, very intelligent people. So what happens is the pain department of their brains, the part of the brain that filters pain, is quite sensitive. So it just can't rest. It just keeps generating pain, right? And that is what we call migraine, and it's so common. So if you step outside now and you just gather 5 women in random, just randomly, just call 5 people, at least one of them would have migraine. So it's that common. So 1 in 5 is that common in women, but in men, probably 1 in 7 or 1 in 8. So it's so common. Maybe you can imagine maybe a 5th or a 6th portion of the world would have migraine, or 7th would have migraine. So that's how common it is. So I like people to understand that they are genetically prone to these headaches. Just like somebody who's got allergies, for example, when they take certain foods or they smell certain things, then they're down, they start coughing and stuff. Have you wondered why they have that? It's genetically determined. So that's what migraine is.
Okay, that's very interesting. I never knew that. Okay, so there's always this, I don't know if this is a myth or it's true, but it's always said that there are certain triggers for headaches that are caused by migraines, not migraines. Is that true?
Great. So you will be correct to use the term interchangeably since we understand what we're saying. So when we talk about migraine as a disease, we're talking about a predisposition. That you and I, for example, I don't know if you've got migraine or not.
I don't know.
You
We'll,
don't know.
we'll see at the end of the episode.
And and a lot of people tell me, no, I don't have migraine. I just have mild headaches. Maybe if I haven't slept well, or if I miss my breakfast, or if I'm exposed to the sun. But that is migraine because it's that natural predisposition to headaches that we call migraine, which some people have and some people don't have it. So it is not everything you're predisposed to that you manifest, all right? And then even when you manifest it, sometimes it's quiet, sometimes it's expressing itself, right? So it's like someone sleeping. So if you tap them and then they wake up. So it's the same thing. So migraine exists in the background. Even when they don't have headaches, there's migraine activity going on, but it hasn't reached a threshold where it gives people headaches. So when we talk about triggers, so the headaches themselves can happen in two ways. So whether or not there is a trigger, migraine headache would manifest at some point. So that is one that is not triggered. But sometimes some things are known to be able to wake it up. So for example, if we were in the same room now, if someone has migraine in this room, if I just bring my perfume and spray it around them, if they smell it, if they are the kind that are sensitive to smell, that can trigger their migraine. So they may otherwise not have had headache today, but because I brought in a perfume to them, that would trigger their migraine. So there are triggers, truly, but these triggers are not the cause for migraine. So this person already has a predisposition to migraine, and then you just brought something to trigger the headaches. So for some people, it's smell. For some people, it's light, if they're exposed to too much light. For some people, it's sleep deprivation. For some people, it's excess sleep. For some people, it's certain foods. So it helps if anyone knows what their triggers are and they avoid it, it helps.
Okay. I think I'm the one with sleep deprivation. So whenever I don't get enough sleep, then I know that next day I have a mind killing me.
Right. So it means you've got a free diagnosis today.
Oh, thank you. Okay. So how are migraines diagnosed for those not sitting in here?
Right. So, I get that question a lot in the clinics. So someone comes and says, Doctor, you know what? My headaches are killing me. And it's so bad, I need to stop this headache before I kill somebody, right?
Yeah.
So, and then when you now tell them that this is migraine and they ask you, okay, what is migraine? You explain exactly what I've told you. They don't take you seriously. They say, no, doctor, you must be kidding, right? That there must be something else. Okay, how can I confirm that this is migraine? Is there a blood test? Is there a scan? No, it's a clinical diagnosis. So now, by definition, if I do a blood test and it's abnormal, or if I did a head scan and it's abnormal, that would no longer be migraine, right? Because by definition, the brain should be normal. The brain should look normal. So it's just a functional state. So that's it. So sometimes we do scans, we do all sort of tests, but all of these tests are to help us exclude or the mimics of migraine. So that's the other end. That's the other point, that there are things that can mimic migraine. Even a brain tumor can present like migraine, because there are not many ways in which diseases or disorders of the brain present. So they can present in a way that looks like migraine or in a way that looks like other primary headaches. So, and that's why a lot of times we do scans to make sure we're not missing something that's masquerading as migraine. But of course, when we take history and we examine people and we do thorough examination, we can say with a lot of confidence, maybe up to 90% or 95% confidence, that we're not missing anything. This is straightforward migraine. Occasionally, we may need the help of a scan to exclude something else.
Okay, but when do you identify, okay, here's some paracetamol for you and you should be okay? Or no, this is something bigger, a migraine, and like you need something stronger or more advanced?
I would answer this question in two steps. One is, when would someone come into the room and I would tell them, just go home and relax and you have no problem, it's just nothing else but a primary headache or a migraine. So we run through some things in our minds, what we call red flags. So we look for them, things that would point to a likely underlying cause for this headache, which we call secondary headaches. And if we do not find them and we've examined thoroughly, we do not see anything else, then we know this is a primary headache, and we just say, okay, all you need to do is take care of this headache. The headache is the main issue. Now, to answer the second dimension of the question about when do we simply say, take paracetamol and you don't need anything else. Now, that would depend on, let's say we've diagnosed migraine, okay? this person has got migraine. You and I now understand that somebody that has migraine has nothing to worry about, right? There's nothing dangerous, right? So when do I need to do something different than just Panadol, right? So that would depend on how many times they're getting the headaches. So if someone is getting headaches every day, then I wouldn't say take Panadol every day, because that can even ruin it can't do a podcast, right? In the middle of the podcast, the head is pounding and they have to excuse themselves. They can't do anything else. And Panadol may not always work. So in such situations, when we see very, very high frequency and it's affecting daily activities or functioning, then we may want to give people preventative medications.
Okay.
And the way I explain that to my patients is, if you are meant to have, let's say, 20 headaches in a month, if I put you on preventative medications, maybe you would end up having only 5 instead of 20. Because what these medications do is they do not wait for you to get the headaches. They work on the brain to say, brain, calm down, you don't need to cause headaches, right? So that's what the preventatives do. So they just help the brain to settle down a little bit to reduce that migraine activity. Or some people are getting very few headaches, but the headaches are so disastrous or devastating that when they get an attack, they can't do anything for 3 days. So you want to give them preventatives to prevent the headaches. But if you find a red flag, then you want to investigate to be sure that there's nothing dangerous other than migraine, because we know that migraine has mimics. I've said it a few times today. Yeah?
Yeah. So what are some of the treatment options for migraines, the preventative ones?
There are so many of them these days. So traditionally, we used to give a lot of tablets. Sometimes we give medications that are maybe meant to treat maybe epilepsy. But we know that research has shown that these medications, besides treating epilepsy, they can also prevent migraines. So we give them. Sometimes medications that are used to treat depression and anxiety, we use them also to prevent migraines, right? Sometimes medications that are meant to treat the heart, we borrow them and use them to treat migraine because they work. So, but nowadays we have medications that are specifically engineered to work on migraine biology. So those are available now. They are migraine specific, but they are extremely expensive. So sometimes there are some of them that you give orally, there are some of them that you give by injections every month. But the bottom line to all of them is that these medications are taken regularly to keep the migraine activity down. So because this brain is so wired to generate pain, it keeps generating pain. So we give these medications to kind of make the brain slow down a bit in terms of migraine activity. And then we are hoping that if you do that for long enough a time, then you would have succeeded in deceiving the brain from remembering how to cause pain, basically. So when you stop eventually, it will take the brain a long time to remember how to cause pain again. That's a simple way to say. So we've got multiple options these days, including Botox. We also use Botox sometimes.
So it's a chill pill, literally. You're asking the brain to chill.
Yeah, asking the brain to chill in a way. Yeah.
Okay. Botox, I think that's to numb the nerve. That I don't know what happens with it.
Yeah. So the concept is Botox is not just, I know women like Botox because it kind of relaxes the muscles in the face and, kind of takes wrinkling away and is for beautification. But besides the muscle relaxing property of Botox, it's also a very, very effective pain medicine. So it's able to work at the granular molecular level to hinder the transmission of pain in the brain, including migraines. And that's why we use it.
What about some non-medical treatments? From your experience, have you found that other activities or some kind of stress release helps with managing migraines?
No, thanks for asking that question, because I think that's probably much more important than medications. And I say it to patients sometimes that medications may not even work if you ignore this natural, simple lifestyle changes that can help in migraine. So things like having adequate sleep is very important. Of course, we also know that oversleeping can also trigger a migraine, but at least people should have adequate sleep and it should be consistent, all right? So at the right time, and the duration should be adequate for such individual. And then number two, hydration is also important. So like today, I think I saw someone in the clinic who was getting a lot of headaches, and they've tried a lot of medications prescribed by physicians and even neurologists, but it's not working for them. And then when we dug into there has to be something making these headaches not to respond. So when we dug into their lifestyle, we realized they were not drinking water at all. In the whole day, they may not even drink water at all. So for them, I've asked them to start making sure they're well hydrated. So something as simple as that can make changes. And then meals as well. The people have regular meals. They're not skipping their meals. This is important as well. Exercise is important. How much coffee you're getting. So all of these are important. So some people overindulge in coffee drinking. And then stress. So stress is extremely important. So there are people that you see a time point in their lives where their headache numbers suddenly shifts. They were getting maybe 2 or 3 headaches a month before, and then at a time point, it suddenly became 10 a month. And when you look at what's the difference between both time intervals, it's simply a change in stress levels. Some of them got new jobs, some of them became moms or wherever. So stress is always a factor. So if one is able to manage stress well, migraine tends to fare well as well.
So are there other things that someone can do if, okay, let's say I'm having a migraine right now. I don't want to just right away run and take medication. Are there some things that we can do? I've heard of ice packs on like the forehead. Does that help, or is that just a myth?
No, it helps. Whatever you think helps you to calm down, whatever you think helps you to focus less on your pain, whatever you think reduces the pain, that's useful. I mean, I recommend it sometimes to people. Even washing the face with cold water sometimes helps. Ice packs, like you said, helps. If you can tolerate music, soft music can help. Relaxation can help. Some people even say when they sleep, if they can sleep through it, that is fine. So, but the precaution is for some people who get devastating headaches, that they get as headaches and it becomes so bad they can't do anything. They have to go to the emergency room eventually. I warn them that there's no benefit in you saying, let me wait and see first whether this headache maybe it wouldn't be a serious one. So let me wait and not take anything. I usually discourage that because when you want to take painkillers, the earlier you take them during a headache episode, the more likely they would work. So if you take your pain medication within the first half an hour, for example, of the onset of pain, it's more likely to work than taking it 2 hours later. So what I say is there's no benefit in checking whether it's going to be a full-blown headache, a full-blown migraine or not. What's the benefit? It's like a fire is starting out in your kitchen and you say, oh, let me just see first whether this fire is going to be mild, whether it's not going to burn.
How far is that going to spread?
Yeah, exactly. So what's the benefit of that at the end? So you just get your kitchen burnt, right? So what I say is if the headache is starting, just find a way to stop it. Either you want to relax or you want to sleep or you want to take your painkillers. If you're busy, just take it and let the pain go away. There's no benefit. And then you chart your headaches, and then so your doctor would know what next to do the next time he sees you, whether the headaches are getting worse or if there's a need for preventatives. Because the preventatives actually, they do not only reduce the number of headaches you get, they also reduce the severity of the headaches, and they also make the headaches more responsive to painkillers. Yeah?
Are there like side effects to migraines other than the pain and the headaches?
Yeah. So I like the way the question is going right now. So it's not all about headaches. So maybe I might have given the impression that it's all about migraine. So that's probably not completely true. So, and that's why some people have come up with the concept of the most bothersome symptoms. So there are other symptoms associated with migraine. So migraine is a package, so to speak. And sometimes for some patients, it's not even the pain that bothers them the most. It's the other associated symptoms that come with it. So things like dizziness can be there. So some people can be so dizzy that they can't even walk. Like just yesterday, I saw a lady who came in and she very likely has migraine with a lot of dizziness. And for her, the headache is nothing. She doesn't care about the headache, but it's the dizziness that's disabling for her. For an entire day, she just can't walk properly. She's just feeling woozy and stuff. So there's the nausea, there is the vomiting, there's the light sensitivity, there's the noise sensitivity, the whole host of things. There's some people even have this brain fog coming with their migraines that they can't concentrate, they just can't think clearly. So there's so many things that come together with it.
Okay, that's great to know. So are there any other myths about migraines that you would like to clarify?
I think the most important thing is to understand that, first of all, a proper assessment by a neurologist or by an expert in headache medicine is more important than a head scan. Because a lot of people, when they come in and you tell them, well, you don't need a head scan, they get upset that they're like, no, I want to have a head scan. So a head scan is nothing but just a picture of the brain. So I think an expert analysis of your symptoms and then careful examination, skillful examination by a neurologist is much more important than just a picture of the brain. So it's not everything the MRIs can solve. Sometimes the MRI is normal, yet there's something serious going on. So it's not everything MRIs can solve. Then number two is that there are mimics of migraine. So one should not assume it's migraine. One has to see a trained expert to take history and examine and be sure that there are no red flags, because a lot of things can mimic migraine, including tumors. Unfortunately, I recently saw somebody, I think in their mid-30s, who has a long history of migraine. And then they came in with a different headache. So, and I like asking this question in the clinic. I shouldn't say I enjoy that. And I asked them to say, is there any difference between the headache you're complaining about now and your previous headaches? Can you compare and contrast the two? And then we could tease out that definitely this is a new headache and this is different. So, and when I examined them, I picked up some clinical signs that worried me that there's probably something else underlying this headache, not just migraine. And then when we scanned them, we saw that they had a brain tumor. All right. So it's not, I mean, we don't say this all the time. This is not to frighten people, but at least it's important for people to get checked. So, and then get an established diagnosis that this is migraine, and don't resort to self-treatment, be guided. So that would be my advice. And then it's not all about medications. Lifestyle issues are important, like all we've identified today.
Yeah. Thank you so much for saying that if there is like a change in the kind of headache you're getting, if it's not the same level of pain, if it's happening more frequently, then please visit a neurologist.
Yes, that's the message.
Okay. All right. Thank you so much for this amazing chat, Dr. John. I mean, it was really interesting. You've said a lot of things that I think no one knew about migraines before.
So I hope you now understand migraine a bit better.
I really do, yeah.
So at the end of this podcast, we'll give you your degree, migrainology.
If it was that simple, I would have had so many degrees right now. Thank you so much.
It's a pleasure.
Thank you to all our listeners for tuning in. We hope you also learned something new today. As you know, we're available on YouTube, YouTube Music, Spotify, Apple Podcasts, and Rami and Amazon Music. Stay well and keep thriving.